Hello dear student, this is Dr. Omid and today I'm going to talk about the joints of the lower limb. Okay, first of all we are going to talk about the junction of the bones of the pelvis. The first junction or the first joint that I'm going to discuss is the sacroiliac joint. This is sacrum, continue with the coccyx, and this is ilium. As I mentioned at the bone section, we said that in ilium we had an articular facet which looks like an auricular of the ear. That's why it was called auricular surface. So, and also the same auricular surface we had it in sacrum. So the joint of the sacroiliac articulation or joint is between the auricular surface of the ilium and auricular surface of the sacrum. This joint is flat joint and it has a very tough and short articular capsule. That's why the type of the joint is simple and the type of the joint is amphiarthrosis, because it has very minimum movement. As you see here, the capsule is very tough and short, and the capsule is reinforced by the ligaments, which is the same name joint. It means the anterior sacroiliac ligament, and also at the posterior surface we had the posterior and deep the interosseous or interosseal sacroiliac joint. There is another ligament also which is indirectly reinforcing this joint or strengthening this joint, is starting at the level of the costal process. As you know, the lumbar vertebra doesn't have the transverse process, instead we say the costal process. So the costal process of the L4, L5, and it's continuing toward the iliac crest and also the iliac and sacral tuberosity. This ligament is called iliolumbar ligament, which is indirectly also reinforcing this joint. As I mentioned, the joint, the sacroiliac joint, it's amphiarthrosis, so it has the minimum movement. Only during the pregnancy, thanks to the influence of the hormone, we have some anteroposterior movement that it's very painful. And another clinical importance of this joint, that usually the people that they are suffering from the pain of the back, and mostly it can be or it can be misdiagnosed, the pain for the vertebral column and pain for the sacroiliac joint. So before you decide that if the pain is due to the problem at the intervertebral disc or the vertebral column, so you have to exclude the disorder of the sacroiliac joint. The next, this is another sacroiliac joint that in the other preparation I can show you here, and here the iliolumbar ligament, and this is the posterior side of this joint. Another joint or connection or junction of the bones of the pelvis is pubic symphysis or symphysis of the pubic bone. If you remember, we had at the pubic bone the surface which is called symphysial surface of the pubic bone, and also here which is the symphysial surface of the pubic bone in this region. These two pubic bones, they are at midpoint, and anteriorly they are connected together, and they are making this specific connection which is through the cartilage connection. It is called symphysis of the pubic bone, or pubic symphysis. Usually between this bone, the symphysial surface, it has a disc, articular disc, which is called interpubic articular disc, that on the lateral side it's usually the cartilage, and in the center is usually the dense connective tissue. Sometimes at the disc region we can find the sagittal fissure. Also in some cases it can be seen. The joint or the pubic symphysis, it will be reinforced by two ligaments. One ligament that is passing above the symphysis, which is called superior pubic ligament, and the other one, it's on the inferior side, that is called arcuate pubic ligament. In some literature also it can be called the inferior pubic ligament, but the main or correct terminology is the arcuate pubic ligament. So these two ligaments are reinforcing this joint. This joint and this junction also, it doesn't have any movement, it's very tough, and again during to the pregnancy it can have some minimum movement that it can cause pain. Another topic that I am going to discuss and is very important according to the topography of anatomy. So we have two ligaments at the pelvic region, and this is one of them is longer and is called sacrotuberous ligament. Sacrotuberous ligament, because is starting from the ischial tuberosity or ischial tubercle, and it goes to the lateral margin of the sacrum and coccyx. That's why they call it the sacrotuberous ligament and longer. And the other ligament, which is shorter, is starting from the ischial spine and is inserted to the lateral side of the sacrum and coccyx, and this ligament is called the sacrospinous ligament. Sacrospinous ligament. What is interesting for these two ligaments, if you remember, we had two sciatic notch at the posterior part of the pelvic bone or hip bone. So this is the greater sciatic notch, and this is the smaller or the lesser sciatic notch, and between them it was the ischial spine. Thanks to these two ligaments, the sacrospinous and sacrotuberal ligament, now we don't have the notch, but we have the foramen, the greater sciatic foramen and the lesser sciatic foramen, and again the border between them is the sacrospinous ligament. It's very important then when we have the muscle, and when we are going to discuss about the muscle, you will see that through this greater sciatic foramen, as if that my finger is the muscle, it passes one muscle which is called piriformis muscle. So when the muscle it passes through this greater sciatic foramen, it's dividing this foramen to two parts. The suprapiriform foramen, which is going above the piriformis muscle, and the infrapiriform foramen, which is going inferior to the piriformis muscle. And the structure that they pass through the suprapiriform foramen, it passes superior gluteal nerve, artery and vein. Is important for your topographic anatomy. At the infrapiriformis or infrapiriform foramen, it passes the largest nerve of your body, which is called sciatic nerve, from the lateral side. Then it passes the posterior cutaneous nerve of the thigh. This is the sensitive nerve that is innervating the posterior part of the skin of the sensitive innervation of the skin of the posterior part of the thigh. Then it passed the pudendal nerve. Then it passed the internal pudendal artery and vein. And finally, it passed the inferior gluteal nerve artery and vein. So again, when we have the muscle, I will show you exactly the piriformis muscle that it passed through this greater sciatic foramen and is dividing it to the suprapiriform and infrapiriform compartment or foramen, that those structures that I mentioned, it's passing through. Through the lesser sciatic foramen, after the pudendal nerve, after the turning around the ischial spine, so it's going back to this foramen, the lesser sciatic foramen, and is the place for passage of the pudendal nerve. Another ligament at the pelvic region is, or the connective tissue at the pelvic region, those are this structure, a little bit is destroyed. So this is the remnant of the obturator membrane. As we mentioned, the obturator foramen is covered by the obturator membrane, this structure that is covering the obturator foramen, except one place that it was obturator groove, and after the covering it with the obturator membrane, it's remaining the canal, which is called obturator canal, and the place for the passage of the same name, nerve, artery, vein. It means obturator nerve, obturator artery, and obturator vein. The obturator membrane, it's the place for the origin of two muscles at the outer surface, the external the obturator externus muscle, and at the inner surface, the other side, it's the origin for the obturator internus muscle. Another ligament that also exists at the pelvic region is that at the region of the acetabular notch, that it was the opening of the acetabulum inferiorly. It's the ligament which is called transverse acetabular ligament that it's closing this notch that later at the hip joint we are going to discuss. The last ligament that is very important, and here we don't have it, but at the muscle session we are going to discuss about this, and I'm going to explain it again. But here virtually I'm going to show you, because this ligament is not a true ligament. As a matter of fact, the ligament is a continuation of the aponeurosis of the external oblique abdominal muscle that is from the abdominal region, is continue to this place, and it's making a very important ligament which is called inguinal ligament. The pathway and the origin is starting from the anterior superior iliac spine, and the insertion of this ligament is at the pubic tubercle. So if you consider my pincet, so this is the passage of the inguinal ligament. So this inguinal ligament, in the according to its passage and pathway, then it's under that there is a two compartment. It will be existing, and this two compartment via the arch that is starting from this region. If you remember, the border between pubic and ilium is called iliopubic eminence. From here there is an arch, or the ligament, or the connective tissue, which is called iliopectinal arch. It's connecting to the inguinal ligament, and in this case we have two compartments. One is here, which is more medially, and one is here, which is more lateral to the iliopectineal arch, is called muscular compartment, and medial to the iliopectineal arch, it means in this place, is called vascular compartment. The vascular compartment, we say it because here from the medial side, it's the deep inguinal lymph node, then the femoral vein, the vessel, and the femoral artery, and finally at the vascular compartment it passes the femoral branch of the genitofemoral nerve. Then the lateral compartment, which is here, it's the place for passage of the muscle which is called iliopsoas muscle, is the muscle which is the junction of the or connection of the iliacus muscle and psoas major muscle. It's passing, that's why they call it muscular compartment, together with the femoral nerve that is innervating it. The most laterally also it passed the nerve which is called lateral cutaneous nerve of the thigh, is a sensitive nerve for the innervation of the skin of the lateral part of the thigh. So after we have the preparation with the muscle, then I will show you the exact, the true inguinal ligament in situ in the cadaver. So that is all about the connection or junction of the bone of the pelvis and the ligaments that we can find it at the pelvic region. We are continuing the joints of the lower limb. So next joint is hip joint. Hip joint is between the femur and the hip bone, specifically the head of the femur and the socket which is called acetabulum, that we mentioned it before, and the true articular facet is the lunate articular facet which is inside the acetabulum. The type of the joint is simple joint because it's between two bones, and according to the shape of the articular facet is ball and socket. And as you see, the head of the femur, it goes approximately 3/4 of the head, it goes inside the socket. Vice versa than the shoulder joint, that it was the 3 or 4 times the head of the humerus was bigger than the glenoid cavity. Here 3/4 of the head, it goes deep to the acetabulum. That's why here is called limited ball and socket or anarthrosis. At the margin of the acetabulum, again the same as the glenoid cavity at the shoulder joint, we have the fibrocartilage structure which is called labrum acetabuli, or the acetabular lip is the fibrocartilage structure that is a little bit is increasing the size of the and depth of the socket. The capsule, it's somehow lax and it's allowing some movement. The capsule is starting at the margin of the acetabulum and anteriorly, be careful, it reached to the intertrochanteric line, but posteriorly the capsule, it's approximately finishing at the 1 finger above the intertrochanteric crest. So approximately 1 centimeter above the intertrochanteric crest, the capsule at the posterior side is finishing. So it doesn't cover the intertrochanteric crest. At the posterior surface is the place for the attachment of the muscles. Concerning the ligaments that they are reinforcing the capsule and reinforcing the joint, we have 4 extracapsular ligament and 1 intracapsular ligament. The 4 intracapsular ligaments, they are those. The first ligament, that is the strongest ligament of your body, and almost it can tolerate around 3000 Newton force, and is starting from the anterior inferior iliac spine. It continues to the anterior side of the joint capsule, and then it's divided one side to the neck of the femur, and the other side it goes to the shaft of the femur. So that's why it looks like a inverted Y or epsilon. So you can look at it. It's starting from the anterior inferior iliac spine, and then is divided to the direction of the neck and direction of the shaft. So this is inverted epsilon. You can see it here. This ligament, it's a very important ligament because it's allowing and is keeping the head of the femur inside the socket, permits the stance. So the standing position that you have, it's thanks to this iliofemoral ligament. The name of this ligament is iliofemoral ligament, and also is keeping the trunk in upright position, and is preventing the trunk is falling backwards. So it's very important, and a strong ligament. So when you are going to sit in somewhere, so when you are standing, so that both bilaterally those ligament left and right, they are very tight, and when you are going to stand, so you are relaxing this iliofemoral ligament, and the pelvic region is going backward, and then you can sit in the chair, for example. Next ligament, which is located is located somehow anteriorly, it's the pubofemoral ligament, the extracapsular ligament. The pubofemoral ligament is starting from the superior ramus of the pubic bone, and it goes to the anterior and inferior part of the capsule. Anterior and inferior part of the capsule. This is the pubofemoral ligament, and the function is limiting the movement of abduction and external rotation. Posteriorly, it's the ligament which is starting from the above of the ischial tubercle or ischial tuberosity, and it's going toward the posterior and above the articular capsule, and this ligament is called the ischiofemoral or ischiofemoral ligament, and this ligament is limiting the movement of the adduction and internal rotation. This is the 3 ligament, the ilio, pubo, and ischio or ischio-femoral ligaments. The 4th one is, as a matter of fact, the continuation of the ischiofemoral and pubofemoral ligament around the neck of the femur, which is called circular zone or circular fiber or zona orbicularis. Zona orbicularis, which is around the narrowest part of the neck of the femur, it's the ligament which is called circular fiber. English terminology and Latin terminology is the zona orbicularis. As a matter of fact, the continuation of the pubofemoral and ischio or ischiofemoral ligament. Those are the 4 extracapsular ligament. Then we have 1 intracapsular ligament. As you see, here is the joint. Here is the capsule. If we cut the capsule and open the head out, you see this ligament. This ligament is arising from the acetabular fossa, which composed of the fatty cushion, which is called the pulvinar acetabuli. It's starting from this region and starting from the transverse acetabular ligament, and it going to the fovea of the head of the femur, and this ligament is the ligament of the head of the femur. This ligament, it doesn't have the important role for the reinforcing this joint, but it's a little bit. Is for the reinforcing. This is the only that if all the ligaments is ruptured and the head of the femur is coming out of the socket, so this ligament is the only ligament that is keeping the lower limb beside the pelvis. So, but the important role of this ligament that is that inside this ligament it has an artery, which is the branch of the obturator artery, and it's passing through this ligament and it goes to the head of the femur, and it's for the blood supply of this region together with the other circumference artery that they are supplying the head of the femur. So the most important role of this ligament, the ligament of the head of the femur, is that the artery is passing inside this ligament for the nutrition of the head of the femur. At the end, the movement of the hip joint is flexion, extension, abduction, adduction, and internal and external rotation, and some small circumduction that I'm going to show you. Okay. Next joint is knee joint, or articulatio genu. Is the largest joint of your body. Is between femur, tibia, and patella. Be careful. Fibula, it doesn't have any relation with the knee joint. So 3 bones: femur, tibia, and patella. The type of the joint is complex or compound or composite joint because first, it's 3 bones. Second, it exists between the articular surface meniscus. The type of the joint according to the shape of the articular facet. The articular surface or facet is between the condyle of the femur and the superior articular facet or surface of the tibia, and of course between them there are meniscus, and also between the patella and the femur, it's the patellar surface or patellar articular surface of the femur and the articular surface of the patella. So this is the shape of the articular facet or articular surface. According to the shape, it's a very complex joint because it's the hinge joint. According to the shape of the articular facet, it's the complex and complicated joint. It's somehow they call it trochogingilimus joint, and because it has some sliding and gliding movement happening between these surfaces and articular surfaces. Concerning the capsule, which is here is just a part of the capsule, it's lax, the capsule is wide, and it's allowing some movement. Of course, the capsule, it doesn't cover the epicondyle region. We need them for the attachment of the muscle. and the ligament that they are reinforcing the capsule and also is reinforcing the joint. There are two types. One type of the ligament are the ligaments that they are called extracapsular ligament, that they are reinforcing the capsule. The other type is intracapsular ligaments, but extra-articular ligaments. So it means that they are inside the capsule, but they are not at the articular facet presenting. We have two types of the ligaments at the knee joint. One is the ligaments that they are called extracapsular ligament, and according to its name, they are located outside of the capsule and they are reinforcing somehow the capsule. The other is inside the joint and inside the capsule. It means intracapsular, but they are not at the articular surface. It means that intracapsular but extra-articular ligaments. First, the extracapsular ligament, we divide them to three parts or three classification according to the position of those ligaments. First group of the ligaments, they are at anterior side. The other, they are at the side, and the other group, they are at the posterior part of the capsule. At the anterior side, here you have the patellar ligament. The patellar ligament, as a matter of fact, is a continuation of the head of the one head of the quadriceps femoris, the muscle at the anterior surface of the thigh. This is the rectus femoris, which is attaching to the patella. As we mentioned it before, so that's why the patella is the largest sesamoid bone, because it's inside the tendon of this rectus femoris, one of the head of the quadriceps femoris muscle. And then from the apex of the patella, it's starting a ligament which is called patellar ligament and is inserting to the tibial tuberosity. So this is the patellar ligament, and parallel with the patellar ligament, which is not that much seen here, there are the retinaculum. The retinaculum, there are the connective tissue, which is continuation of the other head of the quadriceps femoris from, for example, the vastus medialis, and part of the vastus intermedius is continue as a patellar, the medial patellar retinaculum. It's continue at the medial side, and the vastus lateralis is the other head of the quadriceps femoris, is going lateral to the patellar ligament as a lateral patellar retinaculum. So three, the patellar ligament, medial patellar retinaculum, and lateral patellar retinaculum is in anterior side. At the side, there are very important ligaments. They are called collateral ligaments, that we had it also in elbow joint, here and here. The medial collateral or tibial collateral ligament, as you see, is located and is originated at the medial epicondyle and is inserted to the medial side of the tibial tuberosity at the tibia, and it's stronger, and the cross section is triangular shape. And it's very, very important information that this ligament is fusing with the medial menisc. It's fusing with the medial menisc. It's very important information, and a while I will tell you why. The lateral collateral ligament that here I have, or I can show it to you here better. You see that is starting from the lateral epicondyle and inserted to the head of the fibula, and at the cross section is round, and be careful, you can see it doesn't fuse with the lateral menisc. So the lateral menisc at all, it doesn't fuse with the lateral collateral ligament, but the medial one, it's fusing with the, as you see, with the medial meniscus. Finally, at the posterior side, here the capsule is not existing, so just to know that at the posterior side, you don't see those ligaments that I'm going to mention it. There are two ligaments at the posterior side extracapsular, which is called the oblique popliteal ligament, which is, as a matter of fact, is continuation of the tendon of the semimembranous muscle, and the other is starting from the head of the fibula, and it's going upward direction as an arch shape in this direction, and it's called the arcuate popliteal ligament. And these two ligaments, arcuate and oblique popliteal ligament, they are the ligaments of the posterior group of the extracapsular ligaments. Then concerning the intracapsular but extra-articular ligament, there are a ligament that definitely you have heard about this. They are crossing each other. They are called crucial ligament. The crucial ligaments, we have two. The anterior crucial ligament, which is here, and it's very important, you can notice. Here is in anterior side. And the other one is posterior cruciate ligament, which is here, you can see. And the posterior one is much more bigger and stronger than anterior side. The anterior cruciate ligament is starting from the area which is in front of the intertubercular eminence, intercondylar eminence, which was composed of two tubercle, medial and lateral tubercle, at the midpoint of the superior articular surface of the tibia. So this area is called anterior intercondylar area, and this is the place for originating of the anterior cruciate ligament that is inserting to the internal surface of the lateral condyle of the femur. So this obliquely is the direction of the anterior cruciate ligament. Anterior intercondylar area to the internal surface of the lateral condyle of the femur. Then the posterior cruciate ligament. The posterior cruciate ligament is starting the same area but posteriorly. Is the posterior intercondylar area, which is posteriorly to the intercondylar eminence of the tibia is located, and is going obliquely upward to the lateral surface of the medial condyle of the femur. So in this case, these two ligaments, they are crossing to each other, and that's why they call it cruciate ligaments, and they are playing role for the rotational movement. This is very important. Another ligament that I'm going to show you is this ligament. It's the ligament that it's connecting the anterior cross of the lateral menisc, medial menisc, and lateral menisc together anteriorly, and this is called transverse ligament of the knee. Transverse ligament of the knee. Here again, anterior cruciate ligament and posterior cruciate ligament. As you see, we have another ligament that sometimes it can be missing, and is called meniscofemoral ligament. We call it meniscofemoral ligament because it's starting from the posterior cross of the lateral menisc, this ligament, posterior cross of the lateral menisc, and it's going to the medial condyle of the femur, and this meniscofemoral ligament, if it is located behind the posterior cruciate ligament, is called posterior meniscofemoral ligament, and if it is going anteriorly, it's called anterior meniscofemoral ligament. What you can see here is the posterior meniscofemoral ligament, starting always, both of them, from the lateral menisc. Very important information that you have to know is the difference between the medial menisc and lateral menisc. It's very important. Here we have the medial meniscus, and here we have the lateral meniscus. The medial menisc is bigger than lateral, as you see. The medial menisc, it has a semilunar shape, half a moon shape. The lateral somehow is circular shape. Next, the medial menisc is fusing with medial or tibial collateral ligament. The lateral menisc, it doesn't fuse with the lateral collateral ligament or fibular collateral ligament. In this case, the lateral menisc is more movable, is tolerating more stress, but medial menisc is less movable because it's fusing with the medial collateral ligament, and also, as you see, because of the semilunar shape, this is the posterior cross that is usually thicker than anterior cross. So the medial menisc is said that it's fixed to three places: at the posterior cross, at the anterior cross, and at the medial collateral ligament. So that's why it's less movable. But the lateral menisc, because it's circular, the posterior cross and anterior cross more or less they are circulating, so they are fusing in one place here, and it doesn't have any connection with the lateral collateral ligament, so that's why it's more movable. In this case, at the external rotation at the knee joint, so usually it's displacing the medial menisc, and it's caused the rupturing of the medial menisc, and the internal rotation is making the relaxation of this menisc. So in this case, because the medial menisc is much more fixed, it doesn't tolerate any stress rotation, it's 20 times clinically will be ruptured than the lateral menisc that is more movable. The movement of the knee joint, it's very complex movement that I am going to show you. The basic movement at the knee joint is flexion and extension. The normal anatomical position of the knee joint is the full extension when you are standing. It means that when full extension, the medial and lateral collateral ligament and anterior cruciate ligament, they are tight very firmly. Then when you want to do flexion, the initial phase is at the initial flexion when the tibia is going backward. So at the initial, the tibia is rotating around 5 degrees inside. This is called initial rotation of the tibia. And in this case, by this rotation, it's relaxing the medial and lateral collateral ligament and anterior cruciate ligament. And in this case, that in full extension, that is called lockdown knee joint, by the 5-degree internal rotation of the tibia, it means is the key for the opening of this lock of the knee joint, which is called clavius articulatio genu, or the key for the knee joint. It's relaxing these two ligament and anterior cruciate ligament, and in this case, it's called unlocking of the knee joint at the initial rotation of the tibia. Finally, with the continuation of the flexion backward, you see that another phase of the movement, which is the sliding and gliding of the femur against the surface of the meniscus. They are the fibrocartilage, like articular disc, the same material fibrocartilage structure. So they are sliding and gliding on the surface of the meniscus. So in the second phase of the movement, the sliding of the femur against the meniscus of the medial and lateral meniscus. So this is called meniscofemoral phase of the movement between the condyle of the femur and meniscus. And the last, at the maximum extension, as you see, the meniscus and the condyle, they are pushed in the dorsal surface, and in this case we have maximum flexion that we have it. So at the flexed leg to the extended leg, all this phase, they are going vice versa till the lockdown of the knee joint. Another important is the patella. During to the flexion, it's continue or is moving distally, and during the extension is moving proximally. The basic movement of the knee joint, it means because of the hinge joint, is flexion and extension, and only at the flexed leg, in the flexion position, you can do some rotation, internal and external rotation. Regarding the movement at the hip joint, that we said that is ball and socket and limited ball and socket, or anarthrosis. So the movement, the basic movement are flexion, extension, far from the body abduction, close to the body is adduction, some internal rotation and external rotation, and circumduction. Those are the combination of the all movement is circumduction. Then regarding the knee joint, that we said that is the largest hinge joint at the body. The basic movement at the hinge joint, as you know, is flexion and extension, and only at the flexed leg you can have some rotation. So the anatomical position of the body is full extension. It means that the knee joint is locked down. And then when we want to do the flexion, as we said, the consequence of the movement, it means that 5-degree internal rotation of the tibia, and you will unlock it, and then the flexion, it will go and continue to the maximum flexion. Next joint at the lower limb is the tibiofibular joint. Sometimes also is called proximal tibiofibular joint. According to the name, is between tibia and fibula. The part of the tibia, the articular facet, is the fibular articular facet that it was behind and below the lateral condyle of the tibia is located, and the articular facet of the fibula, it was the articular facet of the head of the fibula. According to the simple or compound joint, this is the simple joint because it's between two bone and without any articular disc. And also the type of the joint is amphiarthrosis because the articular capsule is very tight and tough and firm, and the articular capsule is very short, so that's why the movement is very minimum movement, and in this case is amphiarthrosis without any specific movement. This is the compensatory joint at the lower limb. Then, the ligaments that they are reinforcing the capsule are the anterior ligament of the head of the fibula. Of course, here you cannot see, but anteriorly is reinforcing the capsule, and the posterior ligament of the head of the fibula, which is reinforcing the capsule posteriorly. As we mentioned at the antebrachial region, so at the antebrachial region between the radius and ulna, we had the interosseous membrane, and here also at the crural region between the tibia and fibula, we have the interosseous membrane that is continuing joining the interosseous membrane of the tibia to the fibula. At the antebrachial region, the interosseous membrane, it was obliquely from the radius downward to the ulna, and here the interosseous membrane is obliquely starting from the interosseous margin of the tibia directed to the fibula. So this interosseous membrane is very important because it is dividing the different muscular compartment of the body, and also is the place for the origin of some muscle. Concerning the junction between the tibia and the fibula, we have another junction at the distal part of the tibia and fibula. It's called the tibiofibular syndesmosis. This is the special connection between the two bones through the dense connective tissue. That's why they call it syndesmosis, or sometimes it's called distal tibiofibular syndesmosis or distal tibiofibular joint. So this syndesmosis is the connection through the connective tissue, and also it doesn't have any specific movement. The movement is very minimum, and the ligaments that they are reinforcing the capsule, which is very short and tough, is the anterior and posterior tibiofibular ligament. That, of course, here again you cannot see because the capsule was removed to show you the syndesmosis of the tibiofibular joint. Joints of the foot. It's a little bit complicated, but we are trying to simplify these joints of the foot. Joints of the foot, we divide them to the upper ankle joint, which is between the tibia and fibula and talus or talus bone. This is called talocrural joint or upper ankle joint. Then we have the lower ankle joint, that is the connection of the talus or talus with the other tarsal bone that in a while we are going to discuss. Regarding the talocrural or upper ankle joint, this is the joint between the superior articular facet of the trochlea and the medial and the lateral malleolar surface of the trochla of the talus, and with the inferior articular facet of the tibia and the medial malleolar articular facet of the tibia in one side, and the other side it's the lateral malleolar articular facet of the fibula. The type of the joint, it's 3 bones, so they are compound joint, and according to the shape of the articular facet is the hinge joint. So again, whenever you hear the hinge joint, the main movement at this joint is flexion and extension. That again, this joint, it's the movement of this joint, again, it's together with the other joints of the foot. The capsule or articular capsule, it's a little bit lax, so it's allowing some movement. The articular capsule is reaching to the margin of the articular facet, and also there are 2 ligaments reinforcing this articular capsule, that they are very important. One ligament that maybe I show it here. This is again the tibia, and this is the fibula, and this is the trochla of the talus. The articular capsule, we said that is a little bit lax, so it's allowing some movement. And the 2 ligaments, they are the collateral ligaments, the medial collateral ligament, which is of the upper ankle joint, and the lateral collateral ligament, which is at the lateral side of the ankle joint. The medial collateral ligament, it's stronger, and because of the specific shape that it has, it's called deltoid ligament. It's very important ligament. And the deltoid, or the medial or tibial collateral ligament of the ankle joint, it composed or consists of 4 ligaments. The tibio-talar anterior, tibio-talar posterior, or anterior and posterior tibio-talar or tibio-talar ligament, then which is attaching anteriorly to the neck of the talus and posteriorly to the posterior process of the talus. Then we have the tibio-navicular ligament, which is attaching or connecting the tibia to the navicular bone, and finally the tibio-calcaneal ligament. Those are the 4 parts of the deltoid ligament or the medial collateral ligament of the ankle joint. The lateral collateral or fibular collateral ligament of the ankle joint, it's a little bit more weaker than the medial one, and it composed of 3 parts. Again, we have the talofibular anterior and posterior, or anterior and posterior talofibular ligament, and the calcaneofibular ligament. This is the 3 part of the lateral collateral or fibular collateral ligament at the ankle joint. The movement, we are going to discuss it at the end, because the movement, as we said, is together with the other joint. So this is the upper ankle joint. Then we have the joint which is called lower ankle joint, and lower ankle joint, it composed of 2 parts, the posterior part and the anterior part. The posterior part of the lower ankle joint, it's the connection between the talus and calcaneus. If you remember, we had 3 articular facets at the inferior surface of the talus, which were called anterior, middle, and posterior calcaneal articular facet, and 3 the same similar articular facet we had it at the superior surface of the calcaneus, which was anterior, middle, and posterior talar articular facet, that they were joining together, and somehow they are making a cylindrical joint between these three articular facet. And as we mentioned it was a tarsal sinus. When the groove of the talus and groove the calcaneus, they are joining together, and at this place we have the interosseous talocalcanear ligament is positioned, and the tarsal sinus. So once more, the posterior part of the lower ankle joint is between the talus and calcaneus, and the name of the joint, either you can say talocalcanear joint, or the common name is subtalar joint is called. The subtalar joint, that is between the talus and calcaneus and the three articular facet that we mentioned it. So not only the interosseous talocalcaneus ligament is reinforcing this tough capsule, also the medial and lateral talocalcanear ligament also, they are reinforcing this joint. Then this is the posterior part of the lower ankle joint. Then we have anterior part of the lower ankle joint. The anterior part of the lower ankle joint, that you can see it here, very nice. So again, this is another side of this is the left foot. So here we have tibia, and here we have the fibula. To revise with you, this is the talocrural joint. This is the trochla of the talus. And then here it's the connection between talus and calcaneus, the subtalar joint. And now we are going to the anterior part of the lower ankle joint, which has two parts itself, the medial part and the lateral part. The medial part is called talocalcaneo-navicular joint. Talocalcaneo-navicular joint. And the lateral one, it's the calcaneo-cuboidal joint. The talocalcaneo-navicular joint, it's somehow a spherical joint, because as you see, this is the head of the talus, and this is the concave or somehow some socket shape of the you can see articular facet at the navicular bone, which is at this articular facet, these joints, they are making or forming the talocalcaneo-navicular joint. The calcaneo-cuboidal joint, it's an amphiarthrosis joint that is connecting with the cuboidal articular facet of the calcaneus and calcanear articular facet of the cuboid bone, one of the tarsal bone. Very interesting and important is at this joint, the medial and the lateral part of the anterior part of the lower ankle joint is called Chopard joint. Chopard joint is that joint that I opened it here, and you can see all together. And at this area, there is an important ligament that here it's much more better seen, and is important for the proximal amputation of the joint, and that in the case of the need to amputate the foot, so you have to find this ligament, which it looks like a double ligament. So that's why the name arises for this term. This name is called bifurcate ligament. The bifurcate ligament is connecting the calcaneus bone to the navicular in one side and the cuboid in other side at the dorsal part of the foot. So that's why the bifurcate ligament that you can see it here is composed of two ligaments, the dorsal calcano-navicular ligament and the dorsal calcaneo-cuboidal ligament. So in the case of amputation, so you will cut this ligament, and as here again back here you can cut this ligament, and you cut and you will reach to the Chopard joint. That's why this ligament is called key of the Chopard joint, and or clavus articulatio Chopardi is a very important ligament clinically. Continuing with the joints of the foot, as we explained, the Chopard's joint that you can see, it is somehow S-shaped joint that is, as a matter of fact, they form the anterior part of the lower ankle joint. Then we have another joints that they are connecting the tarsal bone individually. So here, if it is navicular bone, you know that the navicular bone laterally is articulated with the cuboid. Or also here there are the three cuneiform bones, the tarsal bones. The medial, the intermediate, the medial was bigger, the intermediate smaller than the lateral cuneiform, that they are called, for example, intercuneiform joint, the connection between these three bones, and also the connection of the navicular with this all three cuneiform, and also the connection of the lateral cuneiform with the cuboid bone. So they are generally, it's called intertarsal joints, that they are connecting the different tarsal bone together, and the ligament again, the dorsal interosseous and the plantar ligament, that they are reinforcing this joint. Another joint that it's very important, and you can see it here, this line, it's the articulation of the tarsal bone with the metatarsal bones, and this joint is called Lisfranc joint. Lisfranc joint, it's articulation of the metatarsal, the base of the metatarsal joint proximally with the tarsal bones. And of course you have to know which tarsal bone is distally or which metatarsal bones proximally is articulated with each other. As I mentioned before, here is the medial cuneiform bone, which is distally is articulated with the first metatarsal or metatarsus hallucis. Again, whenever you hear the terminology of the hallucis, we are talking about the toes of the foot or first metatarsal bone. So here is the first tarsometatarsal joint, and because at the distal part of the medial cuneiform and the base of the first metatarsal, it was a kidney shape. So this has a specific shape and a strong joint. Then the intermediate cuneiform distal is articulated with the second metatarsal. The lateral cuneiform is articulated mainly, we are talking about the mainly because each of them somehow they have a small contact with the neighborhood metatarsal bone. The lateral cuneiform is distally articulated with the third metatarsal, and finally here is the cuboid bone, the tarsal bone, which is distally articulated with the fourth and fifth metatarsal bone. So this is the tarsometatarsal, this line that you can see, this line is the Lisfranc joint, and this line that you can see is the Chopard joint that we already discussed about this. There is like a metacarpal bone that of the hand. Also we have the interconnection of the base of the metatarsal bones together, that is called intermetatarsal joints, that they are all these joints that I mentioned, they are arthrosis, so they don't have a specific movement, or they have very minimum or minimum movement at the foot. So next joint that I'm going concerning the metatarsal joint, also like a hand region, we have the deep transverse metatarsal ligament that they are connecting the head of the metatarsal bones. The next joints that we are going to discuss is the joint between the metatarsal with the head of the metatarsal bone and the proximal phalanx of the foot. Is more or less the rest of the joint is similar to the hand, but the development is not that much perfect like a hand region, but the joint is absolutely similar. So the metatarsophalangeal joint is the ball and socket simple joint because of the round head at the metatarsal and one fossa at the proximal phalanx, at the base of the proximal phalanx. You can see very well the articular capsule, which is this joint, also is reinforced and restricted with the collateral ligament, and also the interphalangeal joint that is between the proximal and middle and the middle and distal phalanx of the foot. It's happening, and it's a simple and hinge joint, and the main movement is the flexion and extension. So at this forefinger we have the two interphalangeal, the proximal and distal, but at the toes, as we mentioned, that it doesn't have middle phalanx like a hand, we have only one interphalangeal joint, that the basic movement is flexion and extension, and the collateral ligament in both sides, they are reinforcing this capsule and these joints. If we look at the sole of the foot or plantar region of the foot, and you want to dissect it one layer by one layer from the superficial to deep, of course the first layer that you would see is the skin, that is very thick, and if I cut the skin and I clean the subcutaneous connective tissue, then I can see this flat sheet of the connective tissue, which is called plantar aponeurosis, which is starting or originated from the calcaneal tuberosity and longitudinal fasciculus. They are continuing to the metatarsal region and distally. So they are mainly composed of the longitudinal fasciculus and some small transverse fasciculus. This is immediately you can see it under the skin, and aponeurosis is the dense connective tissue, which is a little bit is flat. After removing of this dense connective tissue, that here I had to cut it, here you can immediately see the muscle which is called the flexor digitorum brevis, is the small muscle that it's making a flexion of the finger around this region. So here there are the tendon of the long flexors. Here, after the removing of the muscle, you can see this ligament, which is called long plantar ligament. The long plantar ligament is starting again from the calcaneal tuberosity and is continuing toward the cuboid bone and continue distally to the metatarsal bones. And after the removing of the long plantar ligament, then you will reach to the fibrocartilaginous structure of the ligaments. For example, the ligament of the calcaneo, here, for example, the ligament of the calcaneo-cuboidal ligament, the plantar calcaneo-cuboidal ligament, and the plantar calcaneo-navicular ligament, which has a specific name as a spring ligament that is playing an important role for the stability of the foot. So those are the structure that you are going to dissect. So first is the skin, subcutaneous connective tissue, and then we have the flexor digitorum brevis muscle, and then the long plantar ligament, and then the fibrocartilaginous structure, those ligaments mainly, the calcaneo-cuboidal and calcaneo-navicular, the plantar calcaneo-cuboidal and plantar calcaneo-navicular or spring ligament. As you see here, if I show it from the dorsal part, you can see that the dorsum of the foot, if you look at it, we can see two parts of the foot. One part that is located medially and is higher, as you see, is higher, and the other one which is located laterally and is lower. The medial part, they are composed of the talus, then navicular, the cuneiform, and the first 2-3 metatarsal bones. And the lateral part, they are from the calcaneus, cuboid, and the 4th and 5th metatarsal bones. Just at the end, because the joints of the foot is a little bit complicated, so I shortly recapitulate I do the summary for the joints of the foot. The joints of the foot, we divide them to the upper ankle joint or talocrural joint with the talus and tibia and fibula. This is the upper ankle joint. Then we have the lower ankle joint, which has two parts, main part. The posterior part, which is called subtalar joint between the talus and calcaneus, the triarticular facet that we have. Then we have the anterior part of the lower ankle joint, which is the talocalcaneo-navicular and the talocalcaneo-navicular here, and the calcaneo-cuboidal, which is making a Chopard joint. So once more, the anterior part of the lower ankle joint is divided to two parts, the medial side and the lateral side. The medial side, the joint is called talocalcaneo-navicular joint, and the lateral part is called calcaneo-cuboidal joint, which is amphiarthrosis, and here is the spheroid joint. And these two, the medial and lateral part of the anterior part of the lower ankle joint, is called Chopard joint. So of course then we have the joints of between the tarsal bones that they are called intertarsal joints. Then we have the joint between the tarsal and metatarsal, it's called tarsometatarsal joint or Lisfranc joint, that sometimes to the Lisfranc joint also they consider the intertarsal joint, which is joining the base of the metatarsal bones. And finally here we have the metatarsophalangeal joint, and between the head of the metatarsus and the base of the phalanx, and between the phalanges, which is phalanx proximal and media, is called proximal interphalangeal joint, and between the phalanx media and distalis, or the distal phalanx, is the distal interphalangeal joint, except the toe, that it doesn't have middle phalanx, and in this case we have only one interphalangeal joint, which is a hinge joint. That is all about the joints of the foot, and I'm going to show you the movement of the joint of the foot, since they are working all together as a basic movement, which is called flexion and extension, or plantar flexion and the dorsal flexion, and some rotationally movement, which is called inversion and eversion. Regarding the movement at the joints of the foot, because there are the combination of the movement in different joint, mainly the talocrural or upper ankle joint and the movable part of the lower ankle joint. So the basic movement is the plantar flexion. It means that when you are standing on the tip of your finger, this is called plantar flexion. And we have the dorsal flexion. It means when you are standing at the heel of your foot here. And we have a specific movement, which is this movement, which is called inversion. The inversion is a combination of the movement which is called plantar flexion together with the adduction, together with the supination. This is that the medial edge of the foot, it's going in the medial side. And eversion, which is elevating the lateral edge of the foot, which is combination of the pronation and the dorsal flexion and abduction. So plantar flexion, dorsal flexion or extension, or flexion and extension, and inversion and eversion, those are the movement at the foot joints. Dear student, that's all about the joints of the lower limb. I hope you will like it, this recorded video, and it will be useful for you. I would like to appreciate Dr. Petrashek for his assistancy, and I wish you best of luck in your life. Take care of yourself and stay safe and study hard. Thank you for your attention.